So, in my last presentation, what I'll be doing is that trying to summarize some of the pearls that my fellow speakers have given and try to give you the main pointers through this instruction course. Due to shortage of time, I'll be going a little faster. So, as we have seen that it is a very challenging disease to treat HSV in its various manifestations. And there are so many challenges when we come to treatment of varied presentation of HSV. So to make the diagnosis easier, when we consider epithelial keratitis, just learn to differentiate between a true dendrite from a pseudodendrite by keeping these 3 points in mind, that a pseudodendrite may not be a true ulcer. There is absence of dual staining in a pseudodendrite as compared to true dendrite of HSV, and there are no terminal knobs present in a pseudodendritic pattern. Now, look for clues to support your diagnosis when you are dealing with recurrent episodes or a patient with immune stromal keratitis. Look for history of recurrent episodes, footprint scars, and do a dilated retroillumination examination to look for ghost vessels. Now, if we look at this patient who presented on treatment for 9 months with steroids and acyclovir combination multiple times, had recurrent episodes of redness and pain, and you can see a multifocal infiltrate in this patient. We did a corneal scraping, and what we found was microsporidial spores in the stroma. And we did a therapeutic keratoplasty as indicated in this patient, taking eccentric graft to resolve everything. So just a simple scraping could have reached a diagnosis, but the patient was repeatedly being treated for HSV for the last 9 months. So don't fall for the trap of diagnostic momentum. So often we see patients who come to our clinic diagnosed case of HSV keratitis. No, there's no case which is diagnosed case of HSV keratitis when the patient has first walked into your clinic. Look at it from a very fresh eyes perspective. See everything from a very fresh perspective. Don't fall for the trap of diagnostic momentum. Whenever you are in doubt about the diagnosis, do not hesitate in doing a corneal scraping. You might not find anything, but that will not be a loss at all. HSV is a great mimicker, but the same infections which HSV mimic can in turn mimic HSV. So you have to remember that. In terms of treatment, in cases of treating epithelial keratitis, remember that ganciclovir might be slightly tolerated better and have better acceptability because it keeps the vision clear. Acyclovir, when you're giving 5 times a day topically, will keep the patient blurred for most of the day. Keep the patient's vision blurred for most of the day. So ganciclovir is a gel formulation, so therefore keeps the vision slightly better and better tolerability. When to use oral acyclovir in epithelial keratitis? Just when there is associated ocular surface issues, patient is on multiple AGMs, there is a component of neurotrophicity in the patient, and you don't want to harm the surface any further. Any role of dual therapy? Many patients come to us with oral plus topical acyclovir being given in epithelial keratitis itself. There is no evidence that simultaneous use of 2 antiviral agents will help in faster resolution, so don't go for dual therapy in these patients. Now, patients who have a longer time in healing in cases of epithelial keratitis are the ones which have a larger geographical ulcer, those who have a peripheral or limbal lesion because their inflammation is much more, and have associated stromal inflammation, underlying infiltration, and sometimes, very rarely, acyclovir resistant strains. So in geographical ulcer, the cause is usually either a delayed treatment, or the patient has been given topical steroids previously, or the patient is in an immunocompromised state and therefore progressed to geographical ulcer from a epithelial keratitis. And sometimes when you see these infiltration after epithelial keratitis healing, you can add topical steroids after the epithelial lesion has healed, but keep the patient on antivirals as well. Now, this patient came to us with a presentation of decreased vision and was on steroids and antiviral combination for HSV. But when we stained the patient had an epithelial defect. And on scraping, it turned out to be pythium keratitis. Again, not falling for the trap of diagnostic momentum, do a corneal scraping whenever you are in doubt. We stopped the steroids and the patient progressed very fast. So head study we have already summarized. So just the key point, do not rush to add steroids when you are doubtful about your diagnosis, and do not rush to stop steroids when you know that it is HSV immune stromal keratitis. A slow taper is the key here. And I've already given you the regimen to follow in the clinic for effective outcomes and avoiding multiple recurrences that the patient can present with. Now, what is the duration of prophylactic therapy needed? Important factors you need to consider. This question we are asked very often because the patient doesn't want to continue on the prophylaxis. So see that when was the last recurrence? Has it been more than 6 months or 1 year since the patient has had the last recurrence? What have been the number of recurrences that have been there on prophylaxis? Is the patient one-eyed, has a bilateral disease, or a precious corneal graft that needs to be protected? In these scenarios, lifelong acyclovir may be needed. Is there any evidence of renal toxicity previously? The dose might need to be reduced or stopped completely. And remember that patient will benefit only till you are giving the prophylaxis. Beyond that period, there is no benefit of previously given acyclovir. So no clear guideline, but continue as long as possible. And if you are considering stopping, at least there should have been no recurrence for the last 6 months in the patient of steroids. So that is the important keyword here. And as we discussed previously, renal function tests ideally every 3 months, but 4 to 6 months is also fine. Then the last slide is the most important, as I emphasized before also, that the counseling of patients is the key in this scenario. You have to tell them that this is not a local infection, it's a systemic infection, it's in their body. The treatment cannot eliminate it, but only reduce the recurrent episodes. They are bound to have breakthrough episodes. They will ask you often that, why am I having this if I am taking oral acyclovir? So you have to tell them ahead that you might have recurrent episodes, but the frequency will reduce. The need for prophylactic therapy for long-term needs to be explained to these patients, and tell them that recurrence may occur whenever, even if you are on prophylaxis. But the severity might be lesser, the frequency might be lesser. Give them the warning symptoms of recurrence so that they seek early care, and the scarring that happens is much lesser than what it would happen in a severe episode. So tell them that anytime you have pain, redness, congestion, slight decrease of vision, discomfort, come to the clinic straight away. Tell them the gravity of situation, that your vision may get affected permanently if there are repeated episodes that are happening, and that is important to understand. And tell them that they will need repeated renal function tests when they are going to be on acyclovir for long term. If we are true to our patient and honest with our patients, then they will follow our advice to the book. So that is all we have from our instruction course. And thank you everyone for being such a good audience that we didn't expect at 8 o'clock in the morning. And hopefully we were true to our, the instruction course was good enough for you to take some learning points and key points to your clinic, and maybe we will see more and more happy HSV patients rather than unhappy ones.